All right. So good news is that you guys already know most of the peripheral nervous system stuff. So that's why this is going to keep this pretty short because you already had anatomy. So you've covered that in your last semester here. So just a couple things on peripheral nervous system here. Um, what are we talking about? All those neural structures distal to the spinal nerves. Okay, so once the spinal nerve comes together, those rootlets and the spinal nerves go out, that's your peripheral, consider your peripheral nervous system. Okay. Uh, Consists typically of these parallel bundles of axons that are in these nerves. Once the sensory and motor and autonomic parts come together is what we're talking about. Is the peripheral nerves are typically containing motor, sensory, and autonomic. Once you get out past those spinal nerve roots. Okay. Um, there's three connective tissue sheaths within a typical nerve. Okay, three layers. Okay, of sheaths. You have an endoneurium, so endo is inner, and it makes sense. Endoneurium, that's surrounding individual axons themselves. A perineurium packages or bundles a group of axons, okay? And then an epineurium, okay, is the entire nerve trunk, okay? So there's three different layers. And how you damage those layers with mechanically, chemically, that's going to influence the function of your nerves. These are generally mixed nerves, sensory, motor, and autonomic. So here's a picture just showing you the different layers here. So this stuff that's all around these individual axons and the myelin, you see the myelin there, that is the endoneurium. Okay. The perineurium is actually just this little area here that wraps around. So this is perineurium here. I don't know why it's doing that, shooting off to the side with my drawing there. And then the epineurium is all this stuff, including this outer edge here that wraps around those bundles of axons. Okay, so that's the perineurium. And you see you do have blood vessels, veins, and capillaries running within these nerve trunks, okay, and these peripheral nerves. So that's why when you have diabetes and so forth, or peripheral vascular disease, why you have loss of nerve function, neuropathies, and those kind of things, because those start to die back and die off. They're not getting enough nutrition for proper functioning. This is review here for you guys. Peripheral axon classifications. So we've already talked about all this. So this is the axon right here. You have large myelinated, medium myelinated, small myelinated, and unmyelinated. These are typical conduction ranges, and they can see they can vary quite a bit. Here's 7 to 130, even for a large myelinated. It depends on how myelinated and just how large it is. This is the diameters, okay? Then these are efferent axons, so those are motor axons, okay, or autonomic axons that are going out to create an effect or, go to a gland, a tissue, an organ, a muscle, okay, efferent axons. And so we have the A alphas and the A gammas, right, that we talked about that go to somatomuscles or extrafusal muscle fibers and interfusal muscle fibers. And then there's also, we didn't talk about these, is type B and type C, which are associated with presynaptic or postsynaptic autonomic nerve fibers. Okay, and you can see they tend to be slower, less myelinated or unmyelinated. And then the afferent axons or sensory axons are classified as 1A, 1B, or 2s, which are coming from these proprioceptive receptors, and then A delta, which is your fast pain, and then C's, which is your slow pain, and also some of your pain receptors in your visceral structures, organs. Classification of peripheral nerve disorders. When you have nerve dysfunction in the periphery, these are the major classifications. First is a mononeuropathy. So that involves a single peripheral nerve, okay? Not the nerve root, but the peripheral nerve after it's kind of branched off to go to its final destination, okay? Carpal tunnel syndrome is a good example of a median nerve mononeuropathy, okay? Then they have what's called multiple mononeuropathies. Diabetes can be a multiple mononeuropathy. Okay, if it's a peripheral neuropathy, diabetes can fit under a couple different categories as a multiple mononeuropathy or a polyneuropathy. Okay, so this involves inflammation also of blood vessels in individual nerve trunks. There are certain inflammatory disorders that can cause inflammation of blood vessels in certain multiple nerves that can cause this what we call multiple mononeuropathy. I don't know why that wouldn't still be called a polyneuropathy, but they call it a multiple mononeuropathies. It's more than one, but they're saying mononeuropathy there. But a radiculopathy is specifically when you are impacting the spinal nerve, okay? That's right where those dorsal roots and ventral roots come together and the spinal nerve forms. It breaks into a primary rami and a dorsal rami. Those are the back of the body and the front of the body. If you impact it right there, right as it's coming out of the spinal column, that's what causes a radiculopathy. Once it starts to go out and branch into its peripheral nerve, final peripheral nerve parts, then that becomes a mononeuropathy or polyneuropathy if you affect it there after it's branched off. But right where it's exiting out after those dorsal and ventral roots come together, that's a radiculopathy. Typical things that are going to cause that is like disc herniation, bulging back in to that spinal nerve, okay, or a stenosis, especially foraminal stenosis, where the spinal nerve exits out the little foramina outside to get outside the spinal column. And then polyneuropathies, and you could almost put in kind of parentheses peripheral neuropathies there. Diabetes is a polyneuropathy, okay? It's affecting lots of different nerves, and in this case it's a distal to proximal fashion. Guillain-Barré is a type of polyneuropathy affecting peripheral nerves, okay? Demyelination of peripheral nerves. This is classification for peripheral nerve injury, specifically typically a mononeuropathies in most cases we're talking about here. This is when you have some type of physical trauma or damage to a individual nerve. This is the one I would know for an exam purpose as this particular table. Okay, so this is one you should probably highlight, even more so than your book. Okay. There's a classification system. There's a Roman numeral classification system called the Sunderland classification. And then there's doesn't have as many gradations or levels, but the Seddon classification. So I think it's kind of nice to know a little bit about both of those and how they fit into the big picture here. So a Sunderland classification 1, also known as a neuropraxia, is where you basically just have disruption of axonal myelin. Okay, so those little myelin sheaves get traumatized in some way. So if there's pressure, lack of blood supply, any combination of those things, trauma, compression, bumping into it, can disrupt the myelin. Okay. The nice part is that myelin comes back. In the peripheral nervous system, myelin comes back. In the central nervous system, not so much. Peripheral nervous system has NGF in it, nerve growth factor, okay, that allows that process to occur. Typically, you have complete recovery over a period of could be several days, could even be, a couple hours sometimes if it's a real light neuropraxia, over up to 3 months, okay, depending on how long it takes for that myelin to regenerate and how damaged it is, okay. You've all had, where you've fallen asleep or you had your arm in a weird position, wake up and it comes back to life. That's not so much myelin damage, that's just when you've cut blood supply typically to that area and it's reinfusing, the blood is coming back and allowing your nerve to wake up, so to speak. But some of you may have traumatized a nerve enough, or let's say somebody's had compression and surgery for a long time where the person was put to sleep and the surgeon didn't notice. They might be doing surgery for something totally different, but their leg is laying against the little a pole or something, the bed, in the surgical bed, and it's hitting their common perineal nerve coming out or something like that, they may, if that compression is more than several hours, it could be 4 to 6 hours, it might take a few months. You might get enough impairment that the person has to temporarily wear a little brace, which I've had these patients come to me, got to give them a little temporary AFO for the few months till that nerve and we hope that it heals, that it's just a neuropraxia, okay? A Sunderland classification 2, 3, and 4 are all considered what's called an axonotmesis. So now instead of just myelin being damaged, you actually start to damage some of the axons, okay, and the actual axon itself, okay. So in this case, in a level 2 axonotmesis, you get disruption of myelin and axon, but the endoneurium is still intact. So that endoneurium around those individual nerve fibers is still intact, but you've traumatized the axon and the myelin, okay. Typically, you get complete recovery occurs in an anatomical order, and time of recovery is a function of rate of axonal regeneration. Okay. Typically, if the axon is damaged, but that endoneurium is intact and holds everything in place, so this thing grows and returns to function in the same, it makes the same connections, is what we're talking about here. And this can take, I've seen, it's a range. It depends on the nerve and how big the nerve is, but about like a centimeter a month, so centimeter a month is what they talk about as far as regeneration back to its location and reinnervating. Sunderland classification 3 is you get disruption of myelin, axon, and endoneurium. So now the endoneurium is starting to get disrupted, okay? But the perineurium is still intact, okay? In this case, you often get incomplete recovery because of disruption of the endoneurium. Allows some regenerating axons to become misrouted. They will sometimes, if you've actually disrupted that endoneurium, recovering axons may not go back to the same spot, or may struggle finding their location to go to and may never end up there, so you may get incomplete recovery, okay? The recovery rate is similar to the class 2 injury, which we talked about as like a centimeter a month. So if you know where the location of the damage is and you can estimate where, say, you've got some muscle weakness or numbness, where that area has to get to as far as the motor point, and if you measure it with a ruler, you might be able to predict, hey, it might take us this many months, because that's, 10 centimeters, that might be 10 months before you even start to see recovery there. It doesn't work out for everybody, and that's not an exact science, but you might just be able to help people understand if somebody had back surgery, and in the back surgery, something went wrong, and they nicked a nerve or caused compression of the nerve, they wake up, they have foot drop, you're saying the motor point is down here, where they did the back surgery is up here. That's a lot of centimeters to get down there. That might be 24 months or something, or longer than that, to a couple years before you might notice whether you get recovery or not. In the meantime, we got to do what we can to prevent contracture, maintain function, those kind of things, okay? A level 4 is disruption of myelin, axon, endoneurium, and perineurium, but the epineurium, so the outermost layer of the nerve is still intact, but everything else inside has gotten pretty buggered up, so, okay? Recovery does not occur unless surgical repair is undertaken. So if you actually have disruption of all the internal aspects of that nerve, except for just the outer part, it's going to scar down, and you're probably not likely to get reconnections within those areas. And what they actually have to do, if it's damaged enough, is they got to go in and cut it, create a clean cut, and sew it back together. They got to take that little segment out and actually sew it back together and actually do a clean cut and hope then they can get some regeneration. They're getting better and better at this, okay? Number 5, so starting with a Sunderland classification 5, these are classified as a neurotmesis, okay? So neuropraxias are the most, benign, but an axon, the axon's damaged, the neurotmesis, the whole nerve can be transected or cut, okay? So that's a complete nerve transection. It's actually been ripped apart, cut apart, And you have to then, again, clean up the ends and sew it back together to have any chance of that getting reconnected. And then classification 6, a mixed nerve lesion in which a combination of degrees of nerve injury are present in the same nerve segment, okay, including, so you could have neuropraxia, axonotmesis, neurotmesis, and that's pretty common. You know, if you've got a trauma and you damage a nerve, you may have parts of the nerve that are more involved than another, or you have multiple nerves in that region that have various damage going on. So, okay. That was peripheral nerve system. Wish they were all that easy. Any questions on peripheral nerve? What's that? Oh, where was this handout from? On the. Yeah, don't worry about that. Yeah, there's a handout up here that Kristen printed off from Isidore that gives you some of that breakdown. Remember we talked about the like GSA, GVE, GVA, those kind of things, the general somatic afferent, general visceral afferent. We talked about some classification of nerves. Don't worry about that. That's not on the exam. But I had it as a resource because sometimes when you read textbooks, they'll refer to classifications of nerves as like, you know, autonomic nerves or general somatic, general visceral afferent nerves, GVA nerves, those kind of things. But don't worry too much about that. So, yeah. You do have a dorsal root ganglion. And then is it after that? After that. But before it separates again? So the question, she's asking about radiculopathy. So the spinal nerve, dorsal and ventral roots come together, and then it goes into its primary and dorsal rami. If you have problems with, most of the time it's going to happen right at that point where the dorsal and ventral roots come together, because that's usually right where the foramina it comes out, so the disc bulging or the stenosis is going to happen there. But if you were to have something impacting your nerve, even after it goes into the primary rami and dorsal rami, you would still have more of a radiculopathy type presentation. Like if it just affected the primary rami, it would be a radiculopathy just more to the front of your body. You really don't notice that dorsal rami because it's only going to a little strip down the middle of your back and those muscles in your spine and a little bit of skin overlaying the back. So, but it's very uncommon to have pressure or damage to the primary rami. It's usually right at that spinal nerve where it briefly is a spinal nerve before it branches into a primary and dorsal rami. But that's a good question. All right, good news about this. This is also mostly review. We're getting to that point now where we've exposed you to most of the regions of the nervous system and terminology. So this is just kind of going a little more in depth in spinal region and just reviewing some things and talking about a few new things, but most of this stuff is review. So we're going to go back and get a little more specific on anatomy here, okay? So we're in the spinal region, okay? And what do we talk about spinal region? All those structures that are contained within the vertebrae. So that includes your spinal cord, obviously. Includes the little roots because they're still in the spinal canal before you come together and become a spinal nerve. And briefly, the spinal nerve before it goes out and divides into the ventral and dorsal rami. And then also the covering of your spinal cord, the meninges, okay? The 3 layers. So this is just showing you an anterior view of your spinal cord with its nerve roots coming out. Remember we talked about that cervical enlargement and the lumbar enlargement and the cauda equina. We have the little filum terminale that anchors it down to the sacrum, which is that extension of the pia mater, okay, that covering, that microscopic layer of pia that comes off the spinal cord and forms that little tether. Just knowing that we have 8 cervical nerves, and then we have our 12 thoracic, 5 lumbar, and our 5 sacral nerves. The thing you want to remember here is this, and the cervical nerves exit above their vertebral body level, okay? because you only have 7 cervical nerves, but the only one that's different is C8. Then C8 starts to exit, well, it doesn't have a vertebral body associated with it. But then that causes all from there down, all the thoracic level and lumbar levels to exit below the vertebral body. Okay. And then remember the spinal cord ends at the disc space between L1 and L2 for most people, the tip of the spinal cord, and everything rests that then extends down here is all not peripheral nerves because it hasn't exited yet, but they're not, the spinal cord is no longer in play here. It's just the nerve roots as they exit to go off the cauda So let's just, from a standpoint of understanding this concept of where nerve roots exit for cervical and thoracic spine and so forth, let's just kind of talk about that. So let's turn this into a C6, C7, C8. You know, let's do this. We start at C7 here. So C7, C8, T1, T2, okay? What's that? Oh, you're right. Sorry, thank you. Jesus. Really? There's no C8? Are you sure about that? Dr. Phil didn't teach you about C8? It's about 10% of the population has a C8. So, well, we can stick with C6 then. C7, T1, T2. All right, thank you. Let's go to, all right, so let's say that the nerve here at C6 exits above, right? Coming out above. Same with C7. So this is C6, C7, C8, and now we start having below, so this is T1. So here's a case where if I have a bulging disc, here's my red bulging disc here, if it bulges back this way between C6 and C7, so if you read a report that says patient has bulging disc between C6 and C7, disc herniation C6, C7, you're going to expect C7 to be the nerve root that most likely would be impacted, okay? And so in the cervical spine, if you say between C6 and C7, it's going to be the nerve root associated with the lower vertebral body in that relationship, okay? If I say patient has a bulging disc between T1 and T2, because this now exits below, the bulging disc is going to affect T1. So when you get thoracic, lumbar, and below, if somebody says they have a bulging disc between T1 and T2, it's going to be associated with the higher vertebral level, so the T1, okay? So does that make sense? So this is going to be T1 nerve root involvement when you have a bulging disc between T1 and T2, but for C6 and C7, it's going to be C7. That's the most likely involved nerve root. Does that make sense? So let's talk about the ventral and dorsal roots that come off the spinal cord. The ventral roots are formed by several ventral rootlets. They're efferent, motor, okay, and autonomic, typically, unless sometimes in the sacral level we have some parasympathetic fibers that go out the dorsal. But for the most part, ventral roots are efferent, motor nerves, or autonomic nerves that are going parasympathetic, sympathetic type nerves, okay? Then we have dorsal rootlets. Those are afferent, so information coming in, both from the standpoint of proprioception, pain and temperature, but also autonomic function, at least sympathetically at levels of T1 to T1 to L2, or in that region there, okay? Proprioceptive information enters the medial division of those dorsal roots, and pain and temperature, the lateral division. So if you remember, this whole thing is our dorsal root back here. The medial group, so more medial, is the 1As, A betas, 1Bs, 2s, all the fast, large, myelinated proprioceptive axons come in more that medial aspect of the dorsal root, okay? And then the lateral aspect, more lateral here, is going to be your A deltas and Cs, your slower, less myelinated, smaller axons, pain and temperature, okay, and fast pain and temperature, and slow pain, okay? We have segments in the spinal cord, so, you know, each segment is associated with a spinal nerve level kind of thing. So when you say a C6 segment, a C7 segment, it's not this little tiny sliver, it's an actual region in the spinal cord that's a little bit of a, takes up some space, okay? These are defined by the group of rootlets which combine to contribute to those dorsal and ventral roots which make up the spinal nerve, okay? So this is the, you know, this is the segment here. And it's defined by the rootlets, extent of the rootlets before the next group of rootlets begins is your spinal segment, okay? So let's now talk about going from the rootlets into the spinal nerve, okay, and also the primary rami that come off of that. So you have the spinal nerves, which carry all motor and sensory axons of a single spinal segment and exit above the corresponding vertebrae in the C-spine, except for C8, and below for the rest of the spinal column. The spinal nerve splits into ventral and dorsal primary rami once they get through the intervertebral foramen. The dorsal primary rami goes to the paravertebral muscles and the posterior vertebrae overlying this overlying skin. Okay, so just the back. And then the ventral primary rami innervate all the skeletal muscle and cutaneous areas of the limbs and the anterior trunk. So all your limbs are primary rami and the anterior part of your trunk, you know, from about here forward. Remember we also talked about a gray and a white ramus, okay? So those associated with the sympathetic chain ganglia. So let's just highlight a couple of those. There's your root right there, ventral root and dorsal root. Coming together, there's your dorsal root ganglia. They come together briefly. Here's the intervertebral foramen. Comes out, and right here is your spinal nerve, which divides pretty quickly into a dorsal ramus that goes to the back, and then your primary ventral ramus that goes towards the front of the body and side of the body. And then you have your gray ramus, this one here. The first one is the gray ramus, okay? Remember, it goes in the gray ramus, makes its synapse, and then exits out the white ramus, okay, to go back into the spinal nerve. Those two rami together are called the rami communicans or rami communicantes. Together, sometimes they're called that's what they're called, okay? That's to those sympathetic chain ganglia that are just associated with the sympathetic nervous system. Now we're moving down into the internal structures of the spinal cord again, okay? So we have white matter, which we've talked about. We've talked about all the tracks that make up that white matter of the spinal cord so far. The one thing we haven't talked about is what's called the propriospinal axons. So there's actually tracks that run up and down and only communicate between segments within the spinal cord. They're not bringing information from the brainstem or cortex. They're not taking information all the way up to the brainstem or cortex. They're communicating within localized segmental regions between different regions of the spinal cord. Those are called the propriospinal axons. They begin and end in the spinal cord, okay? They're really close to the gray matter, and they communicate between the spinal segments. So especially when you're trying to coordinate these complex reflexes that involve multiple levels of spinal nerves to coordinate that, you know, flexor withdrawal response with an extension, with extension on the other side, that's important for that kind of thing, okay? Also for some of the locomotor reflexes that occur. Once you get them going, these are multi-segmental reflexes that require communication between segments. Then we have the tracks, which we've already talked about, all the motor and sensory tracks that are running up and down through the spinal cord that are going from brainstem cortical cerebellar regions, okay, that are running up and down and communicating with those higher centers. There is a somatotopic arrangement to a number of these tracts, and we'll show you that. So they're kind of layered in there. Certain parts of the tract are associated with certain regions of the body. That's what we mean by somatotopic arrangement. And that comes into play when we talk about certain injuries in the spinal cord and what areas are most involved. That's the white matter. Then we have the gray matter, which we've also already talked about. The ventral horn, which is more motor, is motor, and then the dorsal horn, which is sensory in nature. And then we do have a lateral horn in the thoracic and upper lumbar, which is associated with the autonomic sympathetic nerve fibers that sit in that lateral horn. Those cell bodies, those preganglionic cell bodies sit in that lateral horn. It's also called the intermediolateral cell column is another term used for that, T1 to L2. And then we also have that shows up again in S2 to S4 segments for the parasympathetic cell bodies in the sacral region. Okay, the sacral parasympathetic cell bodies also have a little lateral horn that those preganglionic nerve fibers sit in. Okay. Then we have this laminar system that we use to these phylogenetically. The cells are a little different in these laminas, and they're associated with some specific functions. So we can divide up the gray matter into these layers or lamina that have slightly different functions and slightly different cell structures. But within those lamina, there's also some regions that cross multiple lamina that are called, nuclei, like Clark's nucleus, substantia gelatinosa, that are these named regions, not laminas. So it gets a little confusing, but. So here's a good picture that shows you everything in the lighter blue is sensory white matter pathways. Okay, so we have all of our sensory white matter pathways there that are highlighted in the light blue. The purple, all this stuff right around the gray matter here, these are those propriospinal axons. Remember this dorsal lateral tract of Lissauer back here? That's considered a propriospinal tract. Remember, that's where some pain and temperature will come up, and it'll go up and down a few segments to communicate with multiple segments potentially before it makes its synapse in the dorsal horn. But then we also have some here that are closer to the midline that also allow information to travel between a few segments of the spinal cord to help coordinate these more complex spinal cord reflexes to allow communication without ever going up to the brainstem or the cerebellum or the cerebrum. Then we have our motor pathways. All the red is your motor pathways that you've learned, all those particular pathways that descend down from brainstem and cerebrum, brainstem and cerebral pathways. We talk about, remember, some somatotopic orientation of some of these major pathways. We're not going to talk about all of them. We're only going to focus on a couple of the major ones that have the biggest, that are most laid out in this. They're large enough and they have a somatotopic layering type of path in their pathway. So the first one here we're going to look at right here. That's a sensory pathway, and that's your spinothalamic tract, okay, or your anterolateral system. So this is a sensory pathway. Pain and temperature is laid out in a somewhat somatotopic arrangement, with upper limb and cervical being more medial, and then trunk and lower limb as you move out going more lateral. Okay? That's the pain and temperature. We have also a somatotopic arrangement back here in the dorsal columns. We have cervical, arm, shoulder, trunk, lumbar spine, going from a lateral to medial arrangement here, because you're layering on the proprioceptive information as you move up the spinal cord. So it layers on. So the lumbar spine stuff and lower body gets on there first, and then we have, so that's why we have that fasciculus gracilis, which is lower body proprioception. Then out here is all upper body and up into the cervical region and head and cervical region. The head comes into the trigeminal nerve. So that's kind of the orientation here from lateral to medial, where this is more medial to lateral, cervical out to lower body. It's a little bit opposite for those dorsal columns. This is motor. This is the big lateral cortical spinal tract. Okay, so lateral cortical spinal tract for distal voluntary movement, both upper and lower body. But this is also arranged the same as the spinothalamic, with upper body being more medial, then trunk, then lower body more lateral. Okay, so that's, if you know that, if that's all you know about somatotopic arrangement of major tracts, those are the ones you want to know. Okay. Oh, this is just showing you a segment of the spinal region with your ventral and dorsal roots, nerve fiber, white matter tracts running up and down, your 3 layers of covering here. This is a nice picture showing that. The dura is the most outer layer. We'll get into this in a second. The arachnoid is the next layer, then the pia, this microscopic layer right on top of the neurons and the white matter. See the little end feet here? There's a little space right here between the pia and the arachnoid, and that's where that cerebrospinal fluid is running. Okay, so it's just that little space there, and the cerebrospinal fluid is in that little space running up and down. Not between the dura and the arachnoid, it's between the arachnoid and the pia. Just showing you some, looking at some cross sections so we can tell where we're at here. So, anybody want to take a guess what we're at here? Is this cervical, thoracic, lumbar? What's that? Thoracic, okay, yep. And so this is probably mid to lower thoracic, because we don't have any hint of a fasciculus cuneatus yet. So right here, all we have is this fasciculus gracilis back here. The fasciculus cuneatus doesn't start coming on till when? Till we get above about T6 or so. So we know we're probably below T6 here. So this is actually, it says right here, T10. Did you guys see that? You guys are good. I'm like, I think you can't see that from all the way back there, but I forget how young your eyes are that you can see that. The other thing that gives us away is the shape of it a little bit, the overall shape. What else gives it away? Yeah, you got some nice lateral horns here. Okay, so there's a lateral horn. What else gives it away? What about the size of the other horns? So the size of the dorsal and ventral horns are pretty small, actually, because all you're doing is supplying a few muscles around the intercostals, maybe some obliques in that region, and then you're only getting sensory information from just a small strip of skin around the, area just in the lower trunk. And so you don't need there's not a lot of anterior horn cells, not a lot of sensory processing going on there. So that's why those are kind of small there. There is a region in here. This is Clark's nucleus right here. It's where some of that proprioceptive, unconscious spinocerebellar tracts are coming up to that lower thoracic spine to make that initial connection with Clark's nucleus. This just shows you some cross sections through each of the different levels. So cervical, you see these nice, huge anterior horns and some decent sized dorsal horns. Plus we have a fasciculus cuneatus and gracilis. You see the cuneatus is much bigger because you've got more information coming in from the upper body than even your lower body. And then it's wider, medial lateral, than it is anterior to posterior. More circular here in that thoracic spine. Lumbar has some pretty darn big anterior horns as well. You got a lot of foot muscles and lower leg muscles, and you got big muscles, you got big muscles of the butt, hips, those kind of things. So you got a lot of anterior horn cells that got to send signals to those. Things get a little more kind of just wishy-washy down the sacral segments. The function it just doesn't look as clean as far as the dorsal and ventral horns when you get down into those regions. So we're in the gray matter, and we're going to talk about rexid laminas, okay, those 10 different laminas we talk about. In 10 histologic regions or laminas, I've highlighted or starred the ones that you need to be most concerned about. Okay, so lamina 1 is known as the marginal layer. Lamina 2 which is also most closely associated with the substantia gelatinosa. The substantia gelatinosa is what is considered lamina number 2. It extends a little bit in lamina number 1 as well. This is where you get that initial processing of noxious information. So pain and temperature comes into the dorsal horn and makes its first synapse in this region, lamina 1, lamina 2 region. 3 and 4, some collaterals of your dorsal roots that come in bringing proprioceptive information that go up your dorsal columns, you have some collaterals from those that go and synapse with this nucleus proprius and they give you some proprioceptive input in the dorsal horn, okay, to help modulate activity of the dorsal horn, right, the dorsal horn. So you've got this nucleus proprius. Makes sense. Nucleus proprius, proprioceptive, okay? That includes basically lamina 3 and 4 essentially make up this thing called the nucleus proprius. Lamina number 5, that's mostly noxious information from the viscera, okay? So remember in the past we did talk about with pain and temperature, we talked about lamina 1, 2, and 5. Lamina 1 and 2 are more from the body, the somatic regions of the body, surface of the skin, muscle, bone, those kind of things. The area number 5, or Rex's lamina number 5, is where that initial communication is coming from pain receptors in the viscera, okay? Heart, stomach, gut, those kind of things. Area number 7, lamina number 7, includes the nucleus dorsalis, also known as Clark's nucleus, which we just mentioned, okay? T1 to L2 is where that sits. Remember, that's unconscious proprioception from spinocerebellar tracts that have a synapse with that. Lamina number 8. In lamina number 8, you actually get some communication with interneurons that connect with the contralateral cord. You'll see where kind of it's positioned. It is in a position that's easy to have communication with the other side. Lamina number 9, this is where the cell bodies for lower motor neurons sit. The anterior horn cells, okay, are mostly in lamina number 9. Number 10 also has neurons which cross to the other side. And then in those thoracic and sacral regions that are associated with sympathetic and parasympathetic nerve fibers, there's the intermediolateral horn or the lateral horn. So this is showing you on this side you have Rex's laminas. This side you have those named regions or nuclei. And you can see that some of them are very closely associated with the Rexid laminas, some are not so closely associated and may overlap a few Rexid laminas. The meninges, and then we're in the outside, the covering, we have the pia, which makes up, the other structure it makes up, there's the filum terminale, which anchors the spinal cord to the sacrum, but then there's these things called denticular ligaments, these little extensions of pia that come off the side of the spinal cord and anchor it to the edges of the spinal column, kind of to reduce movement side to side and anchor it that way, okay? Then we have the arachnoid and the dura. So here you see, in this particular picture, the dura is reflected, exposing, you can see this little cut area here, this kind of hazy area. This is all arachnoid. An arachnoid spider-like. It looks like kind of like a spider web when you look at it. It's got that spider webby appearance. And that's where the cerebral spinal fluid is running underneath that arachnoid, okay? You can't see the pia. The pia is a microscopic layer directly on the surface of the spinal cord. But you can see the pia here. Where it does, once it leaves the surface of the spinal cord to form these denticular ligaments, that is pia. These little guys here, these little extensions coming out here, these are the denticular ligaments. So it is pia, which you can see when it forms those denticular ligaments. And it's anchoring it to the dura right there, okay? Let's see if we can hang with me for like another 20 minutes. If you got to run out and use the bathroom, I understand. Then we'll finish, so you guys didn't finish a little early. If I give you a break now and then bring back, let's just try to go through another 15, 20 minutes. But guys, spinal cord function now. We're going to start getting into some functional things. What does it do? A lot, okay? It's not just a conduit for information. There's processing that goes on. There's a lot of processing and modification of sensory and motor output that occurs, and autonomic function occurs right at the spinal cord level, okay? The role of interneurons. We always forget to keep reminding ourselves about these interneurons. These interneurons, you know, are much more prevalent than any of the pathways, any of the other neurons we've talked about. So the interneurons are incredibly important for modulating overall activity. They're the most prevalent class of neuron in the nervous system. You've got 30 times more interneurons in the spinal cord than you do anterior horn cells, okay? Afferent information coming in from the periphery, and the afferent from the viscera, from the muscles, from the skin, comes in synapses. Not only does it go up and down, but it synapses and communicates with interneurons right at those segmental levels. Same thing with information coming down. All the efferent information coming down, motor system information, also synapses on these interneurons. So these interneurons are in a great place to take both afferent and efferent information and say, and they're sensing what is going on in both the environment and the outside environment, but from the internal environment and what you're trying to accomplish. And it modulates then signals. It helps just like your cerebellum helps modulate signals, your cerebrum, the spinal cord helps modulate output and signals, okay? Allows for coordination of even fairly complex movement patterns, especially related to just postural control, locomotion especially. And then the autonomic. We have some pretty good, decent autonomic regulation that occurs just through spinal cord reflexes, okay? We don't have to have a lot of descending control for a lot of our autonomic regulation. We've already talked about some reflexes when we talked about the motor system. We're going to talk about a few more spinal cord specific reflexes that your book mentions. Reflexes, most spinal reflexes are not just your deep tendon reflex. You know, the only one that's that simple with that monosynaptic stretch reflex is that one monosynaptic deep tendon reflex, okay? All the rest typically involve more than one synapse and often more than one segment of the spinal cord. They use those propriospinal nerves to communicate with the level above or level below to coordinate these more complex reflexes. You know, one of those is the withdrawal reflex, okay? Characteristics of it depend on the location and the type of stimulus, okay? So if you're laying down and somebody tickles your foot, you just typically draw up that leg, you know? If somebody pokes you in the thigh, you might extend the leg away from it. So it's a withdrawal reflex, but this is a classic flexor withdrawal reflex. If somebody stretches or tickles the bottom of your foot, or somebody does the top of your foot, you might push away from it. So it's not truly always a pure flexor response. It is very common to step on an object or have somebody create a noxious stimulus at the bottom of your foot, but it's not always that way. It uses multiple muscle groups at different levels. It uses, L5, S1, so you've got to have that communication between the different levels. If you're standing, you also have to induce a cross-extension reflex. So if you're actually weight-bearing and you have to flex or withdraw one limb, you've got to send signals to the other limb, extend multiple muscle groups. Hip, thigh, gastroc has to turn on. All those levels have to turn on to stabilize you against gravity. Okay, you even do trunk. You gotta adjust your trunk as well. So you've got some trunk adjustments that occur when you have to stand on one leg. So this goes up and down the spinal cord to do that.
What if someone's working you on the leg and then you use your arm to stop them? Is that still a reflex?
To push it away?
Yeah. Because you're trying to get rid of the stimulus, but you're not necessarily moving your leg, or is that not considered?
There is some reflex. It's a mix of voluntary and reflex. Usually, if you go like that to push them away, there's usually enough time that you're getting conscious information at the same time you're starting that movement, and you modify it with some conscious information. So there's some reflex aspect to that. Animals, it's even more reflex in nature versus humans. But there's a lot of times with any of these reflexes, other than that pure stretch reflex, usually there's some conscious overlap, influences or modulates the reflex, okay? So this is just showing you, how you might get, here's the stimulus, the noxious stimulus to the bottom of the foot. It goes in at a certain level. In this case, it's S1 of that, represented by that dermatomal area. But it's going to go up that dorsal lateral tract of Lissauer, and it may interact with multiple segments, and both anterior horn cells on one side of the body, and the same side, but also on the opposite side to stimulate flexors on one side, extensors on the other side. Okay, so that's all you really need to know about that. Within our spinal cord, we've talked about some excitatory circuitry there. That's flexor withdrawal response and cross extension. Those are mainly excitatory in nature. But there's these inhibitory circuits as well that are primarily induce some type of inhibition at the spinal cord level. Reciprocal inhibition, okay? This is where you get decreased activity in the antagonist muscle when the agonist is active. So when you're doing flexion of the bicep, your tricep is being inhibited. And that's a spinal cord level action. So when you're sending motor signals to your biceps to turn on, you're also getting some communication from your C5, C6 segments to say, hey, bicep is turning on, let's go down and inhibit tricep at C7, and so it makes that movement easier, okay? This can be somewhat, your body's good though, sometimes it knows if you need to have co-contraction, especially during weight bearing. So if I'm doing push-ups and I'm going down and doing push-ups, and it's primarily a tricep activity, you may notice my biceps still are turned on to create some co-contraction at the elbow, so I don't just, it requires a little more control in weight bearing. But that's because I'm getting sensory input from the bottom of my hands that are telling me you're in a weight bearing position, you're not in an open chain position. And that's right at the spinal cord level that occurs, so it doesn't maybe turn off my biceps as much as if I'm doing an open chain activity like this, where I'm doing just pure tricep and not weight bearing through my hand, okay? And then sometimes this is why we, like, for example, with a stroke patient or something like that, who are having trouble getting them to turn muscles on voluntarily. Let's say I can't get them to do a knee extension in an open chain position. But if all of a sudden I put them in a weight-bearing position and have them do a little partial squat, their quad turns on. Because I'm inducing some reflexes that occur at the spinal cord level that, because of the pressure on the bottom of my foot, it says you're in a weight-bearing position. I'm going to ramp up a little activity in that quad or make it more sensitive to any signals coming down to make it work, okay? So that's, from a physical therapy standpoint, that can help with some of those things. So reciprocal inhibition, typically, again, more play with open chain activities, where especially with fast movements, where you're trying to, like, contract one muscle quickly, but the other one better get out of the way and relax. This one's a little bit sometimes hard to explain. Recurrent inhibition. Recurrent inhibition is inhibition of the agonist muscle and its synergist muscles, okay? It uses this recurrent collateral called a Renshaw cell to exert its influence. It's used to help isolate proper muscle firing for fine control via this process called lateral inhibition, and act as a governor to prevent muscle damage during tetany. So, we already talked about, this is reciprocal inhibition here on that upper, but this is the recurrent inhibition. So let's say I'm sending a signal down to anterior horn cells. Come on. These are the anterior horn cells here. So I'm sending a signal down to anterior horn cells. And I want to contract a muscle. In this case, it's showing like my thumb. And I want to contract that thumb. But I want to contract that thumb in a very specific manner. I don't want to just contract all those muscle fibers at once and just have my thumb do that. I'm really trying to do something with some fine motor control. I'm trying to, with a certain amount of force. So I'm sending signals down to several alpha motor neurons to do that. But I really only want, there's a certain 1 or 2 or 3 that I really want to do the job, not the ones that are nearby. So I'm sending a certain strength of signal to some motor units down there. The ones that are getting the strongest signal are the ones I really want. The ones that are getting some signal, enough to start contracting them, I really don't want them involved. I'm trying to fine-tune my motor act to just the ones that I really want to work. So the ones that are kind of accessories that I really don't want to, but they're getting turned on a little bit, those Renshaw cells will go and inhibit all the motor neurons, but doesn't turn them off totally, but it'll inhibit the ones that are getting the weaker signal. So the ones that are getting the weaker signal, they're going to get even turned off more. So the only ones that'll stay on, even though they're getting a little inhibition, are the ones that are getting the strongest signals. So it's a way of fine-tuning and directing so that only you get those muscle fibers through this thing called lateral inhibition. You're inhibiting the motor neurons you don't want to actually be part of you really want to be part of the action, okay? So only the ones that get the strongest signal are going to stay turned on, even though you're creating some inhibition to all of those muscles. So remember, everything's about this balance between on and off, but somewhere in the middle. And so this recurrent collateral branches back off those motor neurons and inhibits themselves, but it's only going to inhibit the ones that are not getting the strongest signal. The ones that are getting a stronger signal, they're going to get inhibited a little bit, but they're not going to turn off totally. So it's just a way of fine-tuning motor action and motor control. It also is kind of like a check, though. If your muscle goes into tetany and you're actually contracting a lot of muscle groups very strongly, those Renshaw cells can eventually say, you know what, if you're in tetany, your muscle is contracted to the point where you actually don't get very good blood flow and it'll get ischemic. And so if it's too strong that you might get damaged. So we talked about the Golgi tendon organ, thinking it was a fail-safe kind of mechanism. When your muscle was contracting too strongly, it would inhibit it. The Renshaw cell actually does that better. The Renshaw cell actually in the spinal cord will shut its own muscle down if it senses there's too much muscle contraction of too many motor units going on. It'll eventually turn the muscle off, so you can't hurt yourself. Continuing on this theme of inhibitory type circuitry in the spinal cord, there's a thing called non-reciprocal inhibition. Non-reciprocal inhibition is inhibiting all the muscle groups in a certain region. So it might inhibit your bicep, tricep, brachialis. It's a way of just, again, modulating overall activity when you don't want too much activity. And so there may be times when you're doing some sport or some activity that requires this fine grading. You're sending signals from higher centers at a certain level, and your system in your spinal cord will learn that you don't need that much input. And at the spinal cord level, it'll turn down whole limb movements or motor activity in whole limbs. And that's based on you're getting motor signals coming down, but you're getting sensory input coming in. So if you're doing something like this real subtle thing like trying to chip a ball or putt, you only want just the right amount of, you don't want too much, you don't want too little, but you may be sending a signal that's too strong, but your sensor information coming back from when you're doing your little pre-swing to kind of loosen up, you're getting sensor information that says, oh, modulate that down, make all those muscles, loosen them up a little bit, you know. And this can happen somewhat unconsciously at the spinal cord level, that you can modulate overall motor output. There's also a thing called a negative stretch reflex. When you get rapid shortening of a muscle spindle, it inhibits the agonist muscle it's in. So just like if you do a rapid stretch of a muscle spindle, it creates a quick, strong contraction, okay? That's your monosynaptic stretch reflex. If you rapidly shorten a muscle, like the bicep, you're going to get at least a brief amount of inhibition to the muscle, okay? So sometimes we'll take advantage of that, where we'll actually rapidly shorten the muscle and then try to stretch it back out. So if let's say I'm stretching somebody who's very hypotonic or spastic, all of a sudden I notice that I'm catching and they're getting clonus or something like that, I might do a rapid shortening of the muscle, cause that muscle to turn off a little bit, inhibit it. I'm also stimulating the stretch reflex on this tricep, which reciprocally inhibits the bicep as well. And then I'll say, all right, I'm going to slow it down. I'm going to try to stretch this even slower so I don't create that stretch reflex again, and I'm going to gauge it a little slower next time. You know, so it doesn't always work, but that's the negative stretch reflex. This is just showing you, here is, you get all this afferent information coming in from your system. This is this inhibitory interneuron that may communicate with numerous anterior horn cells at multiple segments, okay? So this is showing you a single segmental level, but obviously this is biceps, brachialis, and triceps. Those are not at the same level. So we've got C5, C6, C7 there. but this is just showing you a representation at one level. So that can cause the shaping of motor output. But remember, we also have descending tracts coming in and communicating with interneurons as well, and with the anterior horn cells. And so it's that integration that occurs there that shapes this overall motor output. You know, sensor information coming in, combined with the motor information coming down, that says, and then knowing what the task you're trying to accomplish, that all influences and shapes motor output at the spinal cord level. So some more complex types of reflexes. These are the postural and locomotive reflexes. So we do have some basic stepping pattern generators in the spinal cord. So when I send a signal, typically from my brainstem or cerebrum, you're sending pulses of information down to these stepping pattern generators, just to kind of keep them going. And once they get going, they tend to keep going. And there's certain things that keep them going. One of them they think is actually the stretch reflex. There's a stretch at the anterior hip here when you get into this position of a trailing limb posture, and that stretch stimulates the next volley of impulses back to the spinal cord to, like, okay, take the next step, send a signal to extend the leg on the other side to get ready for weight bearing, then boom, it just does it again each time. And so there's some indications that, for example, patients I work with often take these really short steps if they have Parkinson's or if they have a stroke. They never get into a good trailing limb posture. So what happens is if you don't get into this trailing limb posture and stretch that anterior hip capsule and the iliopsoas, you don't take advantage of the step pattern generator. So every step you have to consciously think about. If you're doing these, that's a total conscious each time you step. But if you get that stretch in the anterior hip and get into a certain rhythm, there's actually a certain frequency that which we step, 60 to 80, steps per minute kind of thing, that helps us. But you got to achieve that certain speed. You'll see with your patients. So my patients that walk really slow, I get them on a treadmill, crank the treadmill up, make them keep their foot on the ground longer, and all of a sudden their gait looks, better, even though you think of, if I go faster, it might make it break down, but there's like this optimal cadence and stretch and sensory influence getting back to the spinal cords that keeps these reverberating circuits going, these reverberating and oscillating circuits. So here's an example of a reverberating circuit. Is first of all, you got to get it started. So you send a signal down to get it started, and that could be initially your cerebrum and brainstem saying start, and then after that the stretches at the hip reflex and even some proprioceptive information from the foot keep it going, keep getting impulses. But once the impulse starts, you see how it sends a signal down here to this one, but then this one has a collateral back to the first one, this one has a collateral back to this one and this one, so they're self-serving, they're self-propagating, so they tend to keep, once you get them started, they tend to keep exciting themselves, okay? And so you have these on both sides of your spinal cord between flexors, extensors that can allow these basic stepping and postural types of reactions. Some of the positive supporting reactions we have of just staying upright, okay, or protective reactions where you put a hand out to catch yourself or a foot out to catch yourself, those are mainly spinal cord reflexes that can help induce that, okay. Also riding reactions. A riding reaction is when you lose your balance, but you still keep your head and your trunk aligned up to vertical, okay? So some of those riding reactions are occurring at the spinal cord level that keep the muscles turned on in the hip and the trunk to keep everything midline, okay? We also have autonomic reflexes that we've talked about. So many functions of the autonomic nervous system are controlled at the spinal cord level. Basic changes in vascular tone, the sympathetic nervous system is most important for vascular tone. Remember, we normally keep a little bit of vascular tone that keeps your vessels slightly constricted, but then you can dilate them or further constrict them from there. So you can upregulate or downregulate. A lot of that happens directly at the spinal cord level, okay, without a lot of influence from higher centers. Localized sweating, in a certain region, not sweating over the whole body, but if you have a certain area of your skin that gets hot and it starts to sweat, that's mediated by a spinal cord reflex, a sympathetic spinal cord reflex that'll cause sweating in a localized region of your body. GI reflexes, basic GI reflexes and motility are at the spinal cord level. Same with bowel and bladder. A lot of bowel and bladder function is controlled at the spinal cord level. We told you about the mass reflex. This is where large portions of the spinal cord activate due to noxious stimuli. This is autonomic dysreflexia we're talking about. So the term mass reflex or autonomic dysreflexia is where you get that unchecked sympathetic reflex. So when you get noxious stimulation coming in, those sympathetic pathways in that T1 to L2 region, those reflexes can go haywire. Normally you do have some descending influence to keep those spinal cord reflexes, whether they're motor reflexes, stretch reflexes, or autonomic reflexes. There is some descending influence that modulates them to keep them at the appropriate level. So you don't over-exaggerate those reflexes or under-exaggerate them. But if you've got a head injury, a spinal cord injury, and, especially above T6 in the spinal cord, now you've lost control over a big enough part of your sympathetic nervous system that those reflexes can go unchecked. Your higher centers are like the check system for those reflexes to keep them modulated at the right level of sensitivity and those kind of things. I think we'll probably stop here. I'm starting to feel done, and I think you guys are done at this point. So let's just pause here. Remember what slide we're on. We'll pick this up again on Friday. We'll do a little quiz on peripheral nervous system on Friday. All right, and we'll do some review on Friday. Good luck with your rest of your stuff this week.